Hi friends, I am Dr. B.V. Rao of Pushra Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the chronic glomerulo nephritis, diagnosis and treatment. Acute kidney injury AKI, previously called acute renal failure ARF, it is a temporary but a sign of large problem. It is the renal insufficiency to perform its normal function. Chronic glomerulonephritis is a chronic kidney disease, otherwise called CKD. It is the result of chronic renal insufficiency condition resulting from the progress of acute proliferation glomerulonephritis or membranous glomerulonephritis. Kidney is a small capsulated, difficult to separate. Peripelvic fat is increased with the reduction of parenchyma. Distinction between cortex and medulla are normal. Most of glomeruli shows fibrosis or hyalinization. Rest of the nephrons are hypertrophied. The production of uremia is resulted by the chronic kidney disease. Body fluid composition abnormally regarding water and salt content, acid-base equilibrium, concentration of nitrogen compounds, finally leading to severe uremia, which is the final stage of renal failure. Symptoms of kidney failure. The kidney failure symptoms are as follows. In some cases, there is a history of acute glomerulonephritis or nephrotic syndrome, identified by the proteinuria and hypertension during a routine examination. Polyuria, thirst, loss of energy, weakness, nausea, vomiting or diarrhea. Polyuria may be due to diminished power of tubular reabsorption of water and may also be due to elevated blood urea production, osmotic diuresis. Kidney pain. Kidney pain is dull in nature and present in the renal angle or in the left or right hypochondrium. Anemia. Anemia is the normocytic and is the main cause of the loss of energy. Hypertension may cause a headache or loss of vision, breathlessness, etc. May be due to cerebrovascular insufficiency. With the progress of the disease, renal function deteriorates and uremia increases and the concentration of urea and other nitrogenous compounds in the blood steadily rises, leading to acute renal failure. The patient looks ill, complexion is sallow, often accompanied by the yellow-brown discoloration due to retention of urinary pigments. Except the patients with the heart failure of hypertension and patient having a chronic membranous glomerulonephritis has followed edematous stage. Other patients are free from edema but usually exhibit signs of water and salt depletion. The skin and tongue are dry and the blood pressure falls from the previous high levels. Acidosis contributes to the dyspnea and the respirations are deep, Kussmaul's respiration. Hiccup, muscular twitching, fits, drowsiness and coma may occur. Bleeding tendency may develop in the terminal phase as epistaxis and epistaxis, bleeding gums, bruises, purpura, hematemesis and melena. Hypertensive retinopathy may be present and visual impairment may develop due to numerous hard exudates arranged in star shape around the macula. In this kidney disease, some patients may complain of vague muscle or bone pain and in some cases become severe. Peripheral neuropathy due to uremia may also occur. Osteomalacia changes may be due to development of resistance to the action of vitamin D, which is probably owes its origin to failure of the kidney to convert vitamin D taken in the diet to the active metabolite in young individuals. This interferes with the normal growth and the condition is called renal rickets. Osteitis fibrosa arises as a result of secondary hyperparathyroidism. The parathyroid gland being stimulated by the low concentration of plasma calcium. The osteosclerosis is of unknown etiology. Investigations. In the beginning, urine contains protein in small quantity. Red blood cells and granular casts are present in small numbers. Glomerular filtration may be reduced to less than 10% of normal, and there is a gradual rise in concentration of plasma urea, creatinine and phosphates. Specific gravity. Specific gravity is fixed 1.010 as the ability of kidney to concentrate or dilute urine is lost and specific gravity is fixed to that level. As acidosis occurs, the bicarbonate levels of plasma are diminished. The concentration of plasma, sodium and calcium are frequently lowered. Potassium occasionally accumulates in the blood and is one of the factors causing death by its effect on the heart. Treatment of chronic glomerular nephritis. The history of the disease can't be altered. Altered and there is progressive deterioration in renal function. The patient's health and feeling of well-being may be considerably improved with suitable treatment. Diet in kidney failure. The onset of uremia may be delayed by restricting the protein intake to 40 milligrams per day and by ensuring an adequate intake of carbohydrates and fat when there is nitrogen retention. In the later stages, when the blood urea concentration rises to 200 milligrams to 100 milligrams, further protein restriction to 20 milligrams per day is indicated. It is best to provide this as first class protein in the form of meat, milk and egg, and to avoid protein of lesser biological value in vegetables and cereals. Fluids. In view of the impaired concentration, power of a large volume of urine is needed to excrete end products of metabolism. So, fluid restriction is contraindicated, except in cardiac failure. A fluid intake sufficient to produce at least 2.5 liters of urine per day should be advised. Salt. Salt restriction need not be considered in absence of edema, cardiac failure, arterial hypertension. In a few cases of chronic nephritis, there is an excessive loss of salt in the urine due to failure of tubular reabsorption, and this may be aggravated by the enforced high fluid intake. Water and salt depletion occur and this aggravates the uremia. Clinical improvement results in such cases from addition of 5 to 10 milligrams of salt per day. The limit to the additional salt is set by the occurrence of systemic or pulmonary edema or by an aggravation of the hypertension. Sodium bicarbonate should be substituted in part for sodium chloride when acidosis is severe and giving rise to symptoms. When nausea and vomiting or coma is there, fluid and electrolytes should be given by intravenous infusion. The volume of fluid required depends on the severity of the salt and water depletion and the degree of acidosis. Average of 5 liters given in 24 hours. 1 part of isotonic sodium bicarbonate, 2 parts of isotonic sodium chloride, and 2 parts of 5% glucose. The infusion is continued till the bicarbonate concentration of blood has increased, if possible, to within the normal range and until the patient is hydrated. Infection. The causative infection like tonsils, infected sinus, root abscess should be removed in order to reduce the likelihood of an exacerbation of acute glomerulonephritis. Antibiotic, as with other, must be used with special care in presence of chronic renal failure, notably benzyl penicillin, tetracycline, aminoglycosides, streptomycin, cephaloridin, and kanamycin. Anemia. It is treated by slow blood transfusion through it is not preferred to increase the hemoglobin concentration above 8.5 grams, as a rapid rise in hematocrit causes a fall in renal plasma flow and a temporary aggravation of uremia. Oral or parenteral iron therapy is ineffective unless there is evidence of complication iron deficiency, nausea, hiccups, vomiting. There may be relieved with chlorpromazine 25 milligrams intramuscularly. Bone pain. Vitamin D in a dose of 5 milligrams calciferol daily orally for several weeks may be used if the bone pain is severe and the radiological picture is of osteomalacia. The treatment should be controlled by chemical estimation of plasma calcium and alkaline phosphatase. For there is a significant risk of producing hypercalcemia and calcification of tissues. Cardiovascular complications. The treatment of hypertension is not a contraindication, provided that there must be taken to see that antihypertensive treatment does not cause a rise in concentration of blood urea. The choice and use of drugs should be made according to the group of drugs. Digoxin is normally excreted in the urine, and hence in renal failure the maintenance dose should not exceed 0.25 milligrams 3 times per week. Hemodialysis and renal transplantation. Repeated intermittent hemodialysis to preserve the life of the same patient with chronic renal failure who are devoid of all renal functions. The transplantation of normal kidney from a healthy donor or a cadaver to patient with chronic irreversible renal failure under legal conditions is in practice. Discreet enquiries should be made regarding the existence of an identical twin. If the healthy twin is willing to donate the kidney, the prospects of renal transplantation are good. Most kidney transplantations are carried out using either kidney from living but less closely related donors or from cadavers. It is customary to try to select a donor kidney on the basis of a pattern of HL-A compatibility, but there is little evidence that this is of importance in cadaver transplants. After 2 years, the survival rate is about 50%, but the post-operative course is completed by the need to give immunosuppressive drugs as prednisolone, erythropoietin, or anti-lymphocytic serum. That's all about the chronic glomerulonephritis, and in the next video I will discuss about some other disease. Thank you.